Hello, I'm Jeffrey Cohen, an associate professor of dermatology at the Yale School of Medicine, where I direct the psoriasis treatment program. Today, I'm happy to talk about the treatment of psoriasis in high-impact sites. The first thing that we need to establish when we talk about psoriasis in high-impact sites is which sites do we mean when we say high-impact sites? And when I say high-impact sites, I mean the scalp, skin folds, so the axillae, the gluteal cleft, the umbilicus, the inguinal folds, genital skin, and then also palmoplantar and nail disease. While we know that plaque psoriasis and scalp psoriasis are the two most common sites of involvement, we also do see a good number of patients who have disease in these high impact sites, and many patients have both plaque and high impact site disease. So it's important to think about these and ask about these when we're seeing our patients because sometimes they may not mention it or we may not see it on exam, but it may have a very large impact on the way that they live their lives and how psoriasis affects them day to day. The other important thing to think about with high impact sites is that both the International Psoriasis Council and the National Psoriasis Foundation consider involvement of these sites to be a reason why an individual may be a candidate for systemic therapy. Now, of course, that doesn't mean that every single one of these patients should be or will be on systemic therapy, but it does mean that we should think about and potentially discuss systemic options with any patient who develops psoriasis of these sites. When thinking about how we may approach systemic therapy, and particularly biologic therapy, in patients with high impact site disease, it's helpful to know which ones work best. And in general, the medications that work the best for plaque psoriasis, these are our IL-17 inhibitors, such as ixekizumab, secukinumab, bimekizumab, and our IL-23 inhibitors, such as risankizumab, tildrakizumab, guselkumab. These tend to work the best for high-impact sites. And when we look at places like the scalp, the skin fold, genital skin, that is really the case, that the medicines we reach for every day for plaque psoriasis are going to end up working the best for these high-impact sites. There may, however, be patients who do not want a biologic that's injected and may instead prefer an oral treatment. And when we look at the data for oral therapies, by and large, they may not be quite as effective as our injectable biologics, but they can still be quite effective for disease in high-impact sites. I'd like to make a special note about nail psoriasis, which tends to be a particularly challenging area to treat. First thing about nail psoriasis is that this has a strong association with psoriatic arthritis. As we know, the nail unit and the joint, particularly the more distal interphalangeal joint, are very close together in terms of location. And so it's easy to understand why inflammation in the nail unit may also result in some inflammation or spillover as inflammation in the joint space. And so a lot of patients with nail psoriasis are going to have psoriatic arthritis. And it's important for those patients to be screened appropriately and for us to really consider this for those patients. Thinking about the most effective therapies for nail disease, this is where I often reach for IL-17 inhibitors in the appropriate candidate. But also there is quite good data for IL-23 inhibitors such as risankizumab in terms of nail disease. It's also interesting to see that in studies looking at psoriatic arthritis, the number of patients with nail involvement taking JAK inhibitors such as upadacitinib did also decrease. And so if someone has a lot of joint involvement and the appropriate choice for them is a JAK inhibitor, that still may help and have good effect with nail disease. Finally, I'd like to say a moment about palmoplantar psoriasis, which is a particularly challenging area to treat. In that case, there is a pustular form, which is very resistant to therapy and often requires combinations of treatments, and then a form that looks like plaque psoriasis on the palms and soles, which is challenging, but not quite as challenging. In general, we like to think about, again, IL-17 inhibitors working well here, as those have shown really good data. And then there is strong data for IL-23 inhibitors, particularly risankizumab, in the non-pustular form. And this is an area of psoriasis that has a high impact on patients' lives, really changes what they can do and how they can function. And so it's important to try to find really good treatments here, and there certainly still is an unmet need. It's been a real pleasure talking to you about psoriasis of high impact sites today, and I hope that this has been helpful in thinking about which medications you may choose for your patients who present with psoriasis and high impact sites, which can have a really big burden on their quality of life And if you can clear this disease, it can be really helpful for patients. So hopefully these have been some good tips, and I look forward to seeing you soon. Thank you for your attention.